Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. It is Wednesday, February 7th, 2018, and we're here for an RN and Allied Health telehealth lecture for the UNC Cancer Network and the UNC Lineberger Comprehensive Cancer Center. So glad that you can be here with us today. If you are experiencing any technical difficulties, now's the time to go ahead and let us know. Just give us a call at 919-445-1000. We do have a team standing by to help you with any technical issues you may be experiencing during this lecture. We'll also record today's lecture, and that will be available in just a day or two in case you miss any portion of the lecture today. We are on the web at unccn.org, including lots of information about upcoming events, past events, a library of over 200 different videos from different presentations over the last several years. We're on Facebook, we're on Twitter, and we're on YouTube, so lots of places to find us. As always, we'll start with a poll, and our poll gives you an opportunity to join Poll Everywhere for today's session. That way you can go ahead and send in questions at the end of the lecture today. It also gives you an opportunity to let our presenter know a little bit about what you know on this topic. The thing you'll do first is you're going to go ahead and text to the number 22333 the letters UNCCN. You'll do that one time, you'll get a message back, it will say join, and then you have joined to the session, and you can go ahead and answer this question and then ask questions at the end. If you prefer to go in through a browser from a smartphone or a computer, you can go to pollev.com/UNCCN, and you can answer questions there as well. But most of our attendees they text to the number 22333, the letters UNCCN, join, and then you can answer this first question. And the question is, according to the Annals of Family Medicine, which of the following is not associated, please note, not associated with provider burnout? And if you think it's option A, lower patient satisfaction, you'll go ahead and select that. B is reduced health outcomes, C is potential cost increases, and D is improving population health. So please go ahead and this is anonymous, select which of those you think is not associated with provider burnout, and we'll discuss that in just a moment. All right. With that, I do want to say welcome to our presenter, Dr. Samantha Meltzer-Brody. Welcome.
Thank you for having me.
Thank you so much for being here today. We're really glad to have you. Let me tell folks a little bit about you. So you are an MD and you have a master's in public health.
Yes.
And you're an associate professor an associate chair for faculty development and director of the UNC perinatal psychiatry program of the UNC Center for Women's Mood Disorders.
Yes.
Also director of the UNC School of Medicine Integrated Wellness Program. Active clinician and researcher, and Triangle Medical Journal recently selected you as one of the top 10 women in medicine. That's a lot of hats and a lot of accolades.
Lots of interesting things to do.
Yeah. Well, we are so fortunate to have you here today. Thank you so much.
Thank you.
Let's take a look at Poll Everywhere and see what we've got.
Okay.
So sometimes we see a trend. We see all three of these running neck and neck. If you haven't already answered the poll, please take just a moment to do that. And again, it's anonymous, but which of these you think would not be associated with provider burnout? So it looks like we should call a close to this one. Looks like C and D are where we're neck and neck. What's the actual answer?
Well, the actual answer is option D.
Okay.
And as we'll talk today, provider burnout has been associated with decreasing patient satisfaction, with delivering worse care and having worse health outcomes, and with it being more costly when you have burned out providers. It hasn't been shown to impact overall population health, although certainly I can understand why people could see that as being something, because you could extrapolate to if it's doing all these things, will it not also impact
Right.
population health. But from the data so far, that has not been examined.
Okay, very good. So presumably we've set the stage by knowing that this causes significant issues, and presumably now you're going to tell our audience some of the things they can do about this.
That's the hope.
Great, great. Well, quick disclosure, and then one other thing I wanted to mention, and then we'll let you move forward with the talk. This activity is planned and implemented under the sole supervision of Thomas Shea, MD, the course director, in association with the Office of Continuing Professional Development. Thomas Shea, MD, consults for Spectrum Pharma and receives research support from Millennium, Otsuka, GSK, BMS, Novartis, and Seattle Genetics. CPD staff have no financial relationships with commercial interests. The speaker, Samantha Meltzer-Brody MD, MPH, has no conflict of interest relevant to this presentation.
Correct.
The one thing I did want to say before we started, part of the way through you're going to be showing a YouTube video.
Yes.
And we have people connected in multiple different ways. For some of you out there, the YouTube experience, basically showing a video through video conferencing, will not be great. The audio should be fine, but the video may be a little bit jagged. So if you want to prepare for that and just watch on your computer, you can just go to unccn.org/video. And for today, we've created a shortcut to Dr. Meltzer-Brody's video that she'll be showing later on. So unccn.org/video. That's a shortcut. You can get that queued up if you want to watch that locally and not see that slow frame rate that you may see through the technology today. So just a warning about that. And we'll talk about that again when we get to the time when that video is there.
Right.
So without further ado, I will pass all the controls over to you.
Great. Thank you so much.
Thank you.
So it's a pleasure to be here today. And I'm going to be talking about the importance of emotional support programs for providers, certainly as applies to physicians, and have titled this, How Do We Take Care of Our Own?, which is also the name of what we started here in 2012, initially for physician mental health, but something we're expanding to all providers. So physician or provider burnout, and please just substitute in provider, but I see all of these things as impacting physicians and every other provider, whether it's allied health professionals, RNs, respiratory therapists, whoever it is that's directly providing patient care, this affects you. And the literature, starting a decade ago, there were papers coming out showing that if you have an unwell physician-provider workforce, then it's impossible really to deliver optimal care for whatever healthcare system is trying to take care of patients. And I think this is very intuitive to all of us. And therefore, wellness is important for the individual provider and the delivery of high-quality healthcare, and healthcare systems should make this a priority. We all know that if you have someone who's impaired in some way, and this is obviously everyone's worst nightmare, you don't want your surgical oncologist taking care of patients coming to work looking like this. You don't want the nurse at the bedside to be engaged in this either. And so whenever we're taking care of patients, the patients are trusting us that we're coming to work in as best shape as possible. And so therefore, the unwell provider really becomes potentially someone who's going to disrupt the delivery of optimal patient care. In 2014, Thomas Bodenheimer and Christine Sinsky, both family medicine docs, wrote a book called The Unintended Consequences of the Triple Aim, and it was called the Quadruple Aim. And they said the care of the patient requires care of the provider. This was landmark in many ways because it was directly responding to what had happened with the adoption of the Triple Aim. And just to go back a little bit, 10 years ago, Berwick et al. Wrote a paper with the best of intentions saying we have to address safety and quality, we have to try and contain costs. He called that the Triple Aim. And as we all know, over the last decade plus, there's been what many would describe as relentless pursuit of decreasing costs, addressing safety and quality. Obviously, all good things, but the unintended costs has been to bury the provider in what can seem like endless documentation, bureaucracy, and really takes away from time spent taking care of the patient to time spent managing all of this. So Bodenheimer and Sinsky, I think, did a brilliant job of calling out that we're missing the fourth aim, which is improving the clinician or provider experience. And that if you have a clinician and provider who's burned out from trying to do everything to accomplish the triple aim, you're not going to be able to be successful in accomplishing the quadruple aim, and certainly in accomplishing the mission of the system. So there's been a lot of talk about burnout. It's a hot topic. People have said to me they're getting burned out hearing about burnout. Why should we care, and what can we do? Burnout is this constellation of feeling emotionally exhausted, increasingly detached, feeling like you have a low sense of accomplishment. If untreated, it can lead to depression. Obvious symptoms: fatigue, irritability, crying, anxiety attacks, change in appetite. Other symptoms can be grinding teeth, self-medicating with drugs or alcohol, difficulty sleeping, low productivity, inability to concentrate. Everyone has episodes of feeling burned out, and certainly in oncology you have a very high stress environment with very sick patients. So we all have moments. The problem is if this becomes persistent. And we know that burnout can lead to depression in physicians and nurses and other allied health professionals. It's common. It's often associated with compassion fatigue. It can lead to attrition, which is a huge issue in our field being, medicine and nursing, that people leave. It leads to adverse medical and mental and physical health consequences for the provider. At its worst, it can lead to suicide, and so it has to be taken seriously and addressed. Tate Shanafelt, who'd been at the Mayo Clinic, is actually a prominent oncologist who worked with predominantly in leukemia, and then was recruited over the last year to Stanford to be their chief wellness officer. He started working on, after Mayo decided to have a very top-down approach and start a physician wellness program, to start understanding burnout and how it was impacting the organization. And Mayo and Stanford around the same time both took a corporate approach and said, if we want to have the best outcomes, if we want to deliver the best patient care, how are we going to have the most optimally functioning workforce? And so they started funding a number of studies on trying to understand burnout in their organization. And this study came out a few years ago, but rates have remained up, and it's become a really difficult thing for everyone in medicine to deal with. But if you look here, you'll see across all specialties that burnout dramatically increased between 2011 and 2014 in a very short period of time. And why would this happen? Why should we see that this being something that would happen so quickly? It's not that all the physicians changed. It's that this really corresponds with the Affordable Care Act, the rollout of EPIC. Again, a lot of things with good consequences, but led to well over 50% burnout in most professions. And oncology is higher than most if you look at medical and surgical oncology. Stanford, after a physician's suicide, again 10 years ago, tried to figure out what are we going to think, how are we going to think about this as an organization, how are we going to have a very top-down approach to seeing this. And they came up with this figure and said there's multiple different domains. We can talk about having people increase their own personal resilience, we can talk about creating a culture of wellness, and we can talk about what may be called the efficiency of practice. Initially 10 years ago, there was a lot of emphasis on the individual and how the individual clinician provider was supposed to be increasing their own personal resilience. And I think a lot of people felt resentful that the system wasn't taking responsibility for some of the drivers and telling everyone to go do their own resilience module. Things then moved into across the landscape nationally. Let's talk about a culture of wellness. How are we creating cultures that are supportive, that support everyone working together? Most recently, I think there's a real call to arms saying the main drivers, and for so many people across nursing, allied health physicians, that EPIC or the EPIC equivalent, wherever you are across the country, has to be changed. Our workflow has to be changed in some way so that people are not unduly burdened by those tasks and can focus their energy on providing great care to patients. What does that mean at UNC? So in August 2016, UNC School of Medicine, the healthcare system, formally adopted the Quadruple Aim. And the goal was to make a statement that the clinician and provider experience was important, and this must be something we would work on. What has that meant other than just being a grand statement, which is nice to make, but it's hollow unless there's things to accompany it? What it's meant is that there's been an effort to really develop an integrated emotional support program that would be available. And this has been piloted at UNC Chapel Hill. And we've spent the last year and a half really working hard to get a number of things in place. The goal in 2018 and beyond is to start exporting this in a very real way across the system. So one of the things that has been developed, the Taking Care of Our Own program, I launched that in 2012, originally for resident physicians, then expanding to faculty. This was focused on physician burnout primarily, and we got philanthropic funding from the School of Medicine. There was enormous uptake of this program, and we quickly realized that there was a need to be able to offer this in ways across the organization and to all providers. And so we started figuring out how could we partner outside of the School of Medicine, but to expand this to nursing and other care providers at UNC Chapel Hill. So we developed an emotional support program and a peer support program. I'm going to tell you about those components today. And again, the goal is to be able to export this across UNC healthcare system in the next year. So the Taking Care of Our Own program started in 2012. Over the first 2 years, we saw an over 200% growth rate. We saw 400 patient visits by the end of 2016. That was maintained or grew in 2017. We give well over 50 presentations a year, this being one of them, to all clinical departments. Referral themes, again, these are residents or faculty physicians, can be issues related to a death or grief in the family in some way, or loss, or difficulty with patient care, relationship difficulties, feeling burned out, being depressed, unprofessional behaviors, marital issues. In a lot of our younger folks and our residents, it can be coming of age issues, anxiety, etc. Sometimes the people refer themselves. That's actually most common. Other times it may be a concerned supervisor, someone working with them, a training director who says, you know, we're really concerned about how things are going. We think you should get some help. The emotional support program initially started with our concern that any kind of adverse patient event, there was not adequate support for the caregiver. And Celeste Meyer, who's in charge of patient safety at UNC Chapel Hill, realized in her work doing root cause analyses that the healthcare providers involved were often just devastated by the outcome for adverse patient events. And we really didn't have good support around any caregiver event-related traumatic events. This can all lead to something called compassion fatigue. And compassion fatigue in the cancer literature is very common. It's described as debilitating exhaustion caused by repetitive empathic responses to patients' pain and suffering. It can result in gradual decreased compassion over time. No one needs to tell any of you that it's sometimes really hard to have enough emotional energy to adequately be able to engage, connect with your patients and what they're dealing with. I like to think of it that we all wake up in the morning with only so much emotional energy, and you can think of it as your cell phone battery. And if you don't do things to recharge, eventually your battery runs out of juice and then kind of shuts down, and so do we. And so this is something that's been published widely in the cancer literature and is something that we all have to be aware of. The constellation of feeling burnt out and having compassion fatigue can also lead to the experience of secondary trauma for the healthcare provider. Let me tell you more about that. Starting about 5, 6, 7 years ago, there started to be publications coming out about healthcare providers being involved in any unanticipated adverse patient event, a medical error, patient-related injury, could feel victimized in some way and traumatized, and that the providers, many would feel very personally responsible, would feel they had failed the patient, second guessing their clinical skills and their knowledge base. And this started being referred to as the second victim. So we were talking about when there are adverse patient events and the impact this can have on the healthcare provider. And a growing literature has talked about secondary traumatic stress. And this can arise from a rescue caretaking response in healthcare workers and includes behaviors and emotions experienced seeing another person's trauma. Most of us who go into healthcare really want to try and do our best and take care of the patients we serve. And so it can feel particularly bad to all of us when we feel that we cannot rescue or save someone from harm. This can cause guilt or distress. This is something that's more widely being understood, and there's efforts now to try and address this. The impact of this is that people can feel frustrated, anger, sadness. Sometimes it can result in full-blown PTSD-like symptoms, decreased confidence, all sorts of symptoms you'll see on the screen. It can really have people maybe think about having a job change, second-guessing their career, feeling sometimes very avoidant of what they're doing, and this becomes a real loss for our profession if people leave the profession due to these kind of symptoms. We know that people working with pediatrics, if you have a string of multiple patients with bad outcomes, which we know sometimes has absolutely nothing about the quality of care being delivered and just can be the randomness of sometimes a string of patients that you've done your best to take care of have poor outcomes, an unexpected death, working with people who were previously younger, healthy, and now they're acutely sick. Sometimes a patient very well known to the staff, if something bad happens, there's a death, that it can be really devastating to everyone who's worked with them. For our trainees and our younger colleagues, the first death on their watch, so to speak, can be really very, very upsetting. So one thing we've been piloting at UNC Chapel Hill is rolling out a peer support program. And one of our recently trained peer support volunteers said, "I believe that the institutionalized support to clinical personnel is one of the greatest failures of medicine today, and I want to be involved in correcting it." And we have adopted a peer support program that's open to all healthcare professionals who provide direct patient care and make professional decisions that directly impact patient outcomes. Jennifer Tauber is an RN who's been working to disseminate this. So far at UNC Chapel Hill, we've trained over 70 peer supporters across all clinical departments, from nursing to respiratory therapy, physicians, everything in between. And the goal is to have people be available to support their peers who have difficult patient experiences. We've been able to get one-to-one peer support conversations covered under the Patient Safety and Quality Improvement Act, and as UNC Medical Center participates in this, therefore these conversations are all protected. That's an important piece, because if there is anything that could potentially result in a lawsuit, people are always very concerned about what constitutes a protected conversation. We've provided basic training during a 2-hour training session, and our goal is to be able to export this model across the system over the next year or so. But this has been really important, and I think that it speaks to the fact that you all have very difficult jobs. Working in oncology, incredibly rewarding, but also going to be very difficult. You're dealing with often very sick patients who can have all kinds of complications. Certainly people you take care of will die, and this is something that everyone in the field has to recognize, figure out how they're going to be supported by the system. But also think about how they're going to take care of themselves. And the system level supports are critical, and certainly addressing those we'll talk about a bit later. But one of the things as a psychiatrist that I think about is we all have to figure out how we're going to recharge our own battery, so to speak. And if we run ourselves into the ground, then we're not able to do our job of taking care of patients or, enjoying our life and our family and friends. And so how you maintain being empathic with your patients, how you maintain being compassionate really requires that you're able to set appropriate boundaries. And so I want to turn this over to I think a really terrific video by Brene Brown, who's a sociologist at the University of Houston. She's written a number of books, has done TED Talks, and I think that she does a lovely job of talking about her research that informs her work on the importance of us setting boundaries so that we're able to have adequate emotional capacity to enjoy our lives, but also for people in healthcare to be compassionate with our patients. So we'll watch the video next, and well, in a minute or so, I guess.
Okay, great.
Okay. But just to highlight, there's a number of different kinds of boundaries that we can think of. Our personal boundaries, personal space, emotional boundaries with others. What are our mental boundaries when people feel like they're hitting a wall, so to speak? Financial boundaries, material boundaries, which is when people fight, about money. Certainly physical safety, spiritual boundaries. So if you take a moment and think about all the different kinds of boundaries in your life, how are you setting boundaries at home, with a partner, with your mother, with family members, with friends? How do you set boundaries at work in terms of what you're being asked to do? How do you set boundaries with patients and families so that you're compassionate and available, yet you're not sucked dry? Because you can't be sucked dry with every patient. You'll not have anything to give and people burn out. So these are really challenging things, and often particularly challenging for very compassionate people. Often the most compassionate people have a really hard time with setting boundaries, and then that can lead to being exhausted, burned out, resentful. So I'm going to have us watch this video now, and I think Brene Brown will be able to share her thoughts certainly much better and I think more eloquently than I can on this.
Here's what's okay for me. And here's
Well,
what's not.
I just want to remind.
Great.
Great message there about the importance of boundaries and being sustainable.
Absolutely. And I think that, for all of us, we have our individual work on how we're making sure that we are doing things that allow us to, if you will, charge our own batteries. How are we doing things to set appropriate boundaries? What are you doing for your own self-care? What are you doing that's restorative to you? It can be any number of things. But that in and of itself is not enough. And so we know from the physician and provider burnout literature that, and certainly as a psychiatrist when I see burned out physicians and providers, if what you say to them is, I'm sorry you're burned out, but really, you should go watch your resilience module and you'll feel much better, people become enormously upset, and rightfully so. And thankfully, I think that this has to be a two-way street, and organizations have to meet people, because people are not burned out because they're not, doing their own self-care. They're burned out because the work we do is exhausting, and there's many system-level contributions to it. So what do organizations need to do? One thing they need to do is just be honest about these dynamics, call it out, make wellness a top priority, measure this. We have to be able to provide emotional support programs, and so I've described some of those. But the next step, and this is, I think right now is a hard thing to do, but this is something that there's active discussions with at UNC, and we're hoping this is going to be a priority in 2018. We have to focus on the structural components, how we see workflow, not just a physician but provider burnout. How do we improve the efficiency of practice? So how does it work for a patient to come in and receive chemotherapy from the time they walk in to the time they leave? What does that mean for the actual provider? What does that mean for how you do workflow? How does your day go on? What does this mean for inpatient care? How much of your life is spent trying to document in Epic versus being emotionally available to the patient? So these are important things we have to figure out, and there's a lot of dissatisfaction right now with how it is now. I want to share with you what we've done on the School of Medicine side, and the idea, again, in 2018 is to be able to export this eventually across the system. for everyone in nursing. This is the Well-Being Index. It was developed originally by the Mayo Clinic. It's 9 items. It's a web-based tool. It provides feedback and resources. The Mayo originally started studying it in physicians. They now use it in 60,000 people in their entire organization. This is now managed by a third-party company. And they have one for nurses. They have one for medical students and everyone in between. And what it does is it gives you, if you will, your own sort of blood pressure read on your stress level, compares it against national norms. A number of large healthcare systems are using this in the country. And then you can sign up to do it once a year, twice a year, with whatever regular interval. It also then provides important metrics for the organization on levels of stress and burnout. And my interest in bringing this to UNC was then to be able to say, we have to develop programs. We need to change the way we do things because we're looking at this percentage of our population, of our healthcare providers, are really stressed and burned out. You can look at it by hospital. So if you look at UNC healthcare system, you can look at it by department. So we can say, what on earth is going on in cardiology? They are much more stressed than someone over here. So it provides helpful metrics both for the individual and for the system. The other thing I'll just say is it also connects people with great resources. So both local resources, national resources. So a lot of good things about this. Again, right now it's been rolled out the past year within the School of Medicine, and the goal is to be exporting it more broadly. So this is an active thing to be on the lookout for, hopefully later this year. And I want to end about talking about the business case for investing in physician well-being. This was written by Tate Schoenfeld and Christine Sinsky. So Tate, who, again, interestingly, as an oncologist and now at Stanford as their chief wellness officer, and Christine Sinsky, one of the co-authors of the Quadruple Aim, who's working for the American Medical Association now. They recently wrote a piece that came out in September talking about the business case. And I think they were really going after people at the top of healthcare systems making the financial decisions and saying, really, if we want to include progress, we have to have the systems buy in and see this really as a critical business model. There is no doubt that if you look at physicians, if you look at nurses, if you look at turnover, how costly it is to replace people, that patient care is impacted by a burned out workforce. We have to make this a case. And if we look at this slide from what happens at the novice level of an organization to an expert level, you'll see at the novice level, you finally get people to say this is a problem. You say, let's have a wellness committee. We'll offer mindfulness training, and you send out some resources for where you can go exercise. As you move across, you can start peer support. You can start measuring things. It really takes at the far end on, the right side, the expert model is the third bullet point down saying you have a chief well-being officer and the executive leadership team. Right now that would be just about one. That's Tate Schoenfeld at Stanford. He's writing the article. So he's clearly seeing that as the optimal place to get to, and I think the journey across. But we have to get beyond saying let's have a wellness committee and mindfulness training. We have to get to where we're redesigning practice. So that I see as being just at the competence stage. You're measuring things. You're giving physicians and nurses and providers are all engaged in how we design our unit, how we design workflow so that it works for both the patient care but for the providers. And this then becomes something that we embrace as an organization. So just to conclude, and then I want to open it up for questions and discussion, physician and provider burnout, it benefits the organization, the individual physician, provider, their family, and high quality health care. This is critical from a business point of view for organizations because it increases productivity, engagement, and decreases attrition. We see this in our experience to date here and the experience of a few other places like Mayo and Stanford, that improvement is possible, the investment is justified, the return is measurable, and that not only is this the ethical thing to do, it's also the fiscally responsible one and critical for success. So I'll end there and we'll open it up for questions and discussion.
Great. Thank you so much. So I'll go ahead and move this over. Just a reminder, If you didn't join Poll Everywhere earlier, just text to 22333 to that number, and you're going to text the letters UNCCN one time. You'll get a message that says join. If you did that already earlier, then you can just go ahead and start texting in those questions. Here's Poll Everywhere, and we don't have any questions yet, but we'll look forward to seeing those in just a moment. I have a few to get us started.
Sure.
To help us understand better how one differentiates between just an isolated instance of burnout, it's been a hard day, hard week, etc., and when there's really a trend going, and this is not just isolated instances, but there's something more significant that needs to be addressed.
Sure. So we all have bad days. I think it's really about persistence and duration and severity of symptoms. So often these things creep up. They don't necessarily come down, as a big hammer unexpectedly unless there's been a traumatic event. But oftentimes people will start feeling less enthusiastic about getting to work. Everyone starts getting on your nerves. You are exhausted all the time. People will talk about coming into work looking what they have to do and feeling like they have to climb Mount Kilimanjaro. What used to be okay absolutely starts feeling overwhelming. People can start feeling more irritable, more sad, changes in how they're sleeping. I think we all have to pay attention to if you start coming home and the first thing you feel you need to do is say, I need a beer or two or three. So I think that we all have to be aware of all of this. And, I think it's really important to pay attention to how you're doing. So I encourage everyone to check in with their own sort of energy barometer once a week.
Okay.
And if you're seeing that, things are lower than usual, if you're feeling like you're running on a quarter of a tank of gas and then increasingly on fumes, then you need to take that seriously.
Okay, good. Thank you.
Sure.
All right. The first question came in. What do you think of the Code Lilac program?
I do not know what the Code Lilac program is in great detail. I've heard a little bit about it. What little I know about it is it sounds very appropriate, and I think that the idea of people reaching out and things that can be done to let people know that they are stressed and sort of at the end of their rope and need help is a very good thing.
Great, sure. And could you briefly describe for anyone who's not familiar at all with that?
Yeah, again, I don't know it in great detail myself, so
sure.
it would be better for someone who's participated in it. But what I've seen in the literature is that it's very positive.
Terrific.
Yes.
All right, thank you. Any difference in burnout with providers who work part-time and have a lighter patient workload?
It's a great question. I don't think there's a lot of studies specifically that has been done on that, but it intuitively makes sense. I think it really depends on many people choose to work part-time because they want to have more time away from work. And partly it depends on what else are they doing in that time. So if they're working part-time, but the rest of the time they're taking care of an aging parent that's very difficult, they may not feel they have adequate time for recharging. If they actually are able to work part-time because they have time to do things that are restorative and they actually feel that more time away from work gives them a chance to recover, that may be a good thing. But it's a great question, and unfortunately, there has not been a ton of literature on that specific question.
All right, and thank you. These are great questions that are coming in. Please, if you haven't already shared one with us, we still have a few more minutes for questions, so please keep sending these in. Is the condition of hypochondria seen under the umbrella of burnout?
So for many people, the way they express their body, their mind expresses distress is all kind of physical symptoms. So there are many people who will never be comfortable saying, I feel sad or blue or anxious, but they'll have unrelenting headaches, stomach upset, any number of psychosomatic symptoms. So there's a lot of people that are very body focused. Their symptoms of stress come out in their body. As a psychiatrist, I think the mind-body connection is indisputable, and we have to listen to our bodies. And so I know I'm stressed when my shoulders are up by my ears and the entire back of my neck starts clenching, and that's a time to really start addressing what's going on. I also know I'm stressed when the nice lady at the checkout counter at the grocery store, my perception is she's not scanning things fast enough. That also lets me know that it's actually not her, it's me. So I think we all have to just pay attention to where we are on this, and then the question becomes, what are we going to be able to do about it? And that's certainly the harder thing. What can be done at work system-wise, what can be done in your immediate environment, and what can you be bringing to the table to ensure that you have restorative time? And these things are hard. They're really hard.
Thank you. Tell it, the presenter in the video, she really emphasized the importance of boundaries and the necessity of that for sustainability. What do boundaries look like? What do healthy boundaries, I get two questions. I'll start with what do healthy boundaries look like, and then maybe we can follow up with, are there unhealthy boundaries? Can you go too far? But first, what would we see in somebody who is exhibiting healthy boundaries?
Right. So I think one of the most important things about healthy boundaries is that you are making sure you have time to do things that are restorative, and you feel there's a clear sort of line in the sand that you're not having to give more than you actually emotionally feel you have the ability to do.
Okay.
So medicine will, the field of medicine will reward people for sort of working for eternity. And I think that there can be this like very macho sense of, but they were there endless hours, 7 days a week, taking care of patients. Well, the reality is for most people, that is not remotely sustainable. And it causes huge tolls on the individual healthcare provider, on their family. And so you have to figure out what is your max where you're done. How do you go and do something that's restorative? How do you have enough juice to make sure you're engaged in the rest of your life? And how do you make sure, you know, on the personal level that you're going home to a place that feels safe and supportive? Certainly people that are in abusive relationships, if you have an abusive coworker, if your spouse is, you know, abusive, those are, you know, things that need to be identified. But we have to take a look at our boundaries, and in this talk we went through sort of multiple definitions. Do you feel that there's adequate boundaries in place between what makes you feel comfortable and the environment you're working in, as well as your home environment?
Great, thank you. And then to that follow-up question, can we go too far? Is there such a thing as having too many boundaries, and
Right.
What would that look like?
So, you know, medicine is a field where it's unpredictable. We can't walk into work every day and know exactly what's going to happen. Patient care is inherently stressful. People get sick at unexpected times. Inevitably, there will be the Friday afternoon urgent call. And so I think people working in healthcare are hopefully able to roll with that to some extent. Right. People in healthcare that are having a hard time with that and start trying to put boundaries that make it impossible for them to do their job.
Gotcha.
That's a problem. So if I said I'm only working, you know, on Wednesdays between this hour and this hour, they would say that's lovely, but you won't be working here anymore.
Yeah.
If I said I'm never taking call on weekends, or I refuse to work weekends, that also wouldn't allow me to stay employed in this particular job. So I think you have to figure out what are the boundaries you need in your life, and in the workplace, are those aligned and compatible with the expectations of your workplace? And they have to align well enough. And if not, then something has to change, and either that can be your work environment, or a different change of some kind. But that's just really important to know. What do I need? What does the organization need? And are we aligned or not?
Right. And I'm going to guess that a lot of the issues with burnout can be addressed with a lot of the strategies you've been talking about today. When do we know that it's beyond that, and that it's actually time for a new setting or altering one's career? You've taken the vacations, you've taken the breaks, you've set the boundaries. Right. It does there come a time for some individuals when none of those are working? Absolutely.
And so when I see people who are in distress, the first thing is figuring out what's driving all of this. And often it's multifactorial. How do we try and address this? Ultimately, I think and no one needs to tell anyone working in oncology this is, we get one pass at life. This is not the dress rehearsal. This is the real thing. Yeah. And people have to decide, is my current environment working for me? There's very real considerations, the pesky details of paying the rent or the mortgage and making a living. But for well-trained healthcare professionals, it's important that we feel supported in our work and that the organization is supporting what we're doing. We feel our goals are aligned. And so I think that's something critical that UNC Healthcare and the School of Medicine are taking really seriously right now. I'm increasingly encouraged that this is something we can make ongoing progress with and do better for all of us that are working so hard to take care of patients. This is a national struggle that's here, there, and everywhere, so everyone's wrestling with it, and it's really figuring out how can we bring innovative and novel things, how can we work together on the individual and system level. So complex, but I think that I'm hopeful we can make good progress.
Good. Well, thank you.
Thanks
this has
for
been
having
a
me.
great presentation, great discussion. I want to wrap up with just a few things here. So I want to thank the North Carolina General Assembly for their generous support of UCRF, what we call the University Cancer Research Fund, and the UNC Lineberger Comprehensive Cancer Center. I also want to thank Mary King, Veneranda Obore, and John Powell for all the wonderful work they are doing today and every day to make sure that each of these lectures can be produced and viewed. Not only now, but in the future, and this will go into our learning management system where you can view the lecture later and receive credit for it even if you couldn't be here today. And so please spread the word. If you enjoyed this lecture and have a colleague who you think would enjoy it and would also like to get credit after the fact, that person can do this through our portal, learn.unccn.org. All right, coming up February 21st, Medical and Surgical Oncology Lecture, Immunotherapy Advances in Lung Cancer with Dr. Chad Pico. I look forward to having him as our next speaker. Then on the 23rd, our Community Lunch and Learn, Finding Peace in the Storm, Managing Stress with Mindfulness with Dr. Susan Gaylord. And then on March 14th, RN and Allied Health Lecture, Widowers, Fathers, and Cancer, the Impact of Loss on Families with Dr. Donald Rosenstein and Dr. Justin Yap. We're very excited about that one. They just published a new book on this, and we're very fortunate that we've gotten them here for a lecture coming up soon. We hope you can be here for all of those and lectures throughout the year. Again, unccn.org, our library, coming events, all sorts of things that you can find there. If you have questions or comments, don't hesitate to call us at the number on the screen or email us at unccn@unc.edu. We're on Facebook, Twitter, YouTube. Thank you so much for being here again.
Great. I really appreciate it.
Absolutely. We're so lucky to have you here today. Thank you to our audience. Thank you for the questions. Thank you for being here with us, and we'll see you next time.